picture this. You're just sitting on your couch on a Tuesday evening.
Right. Maybe just watching television.
Exactly. And suddenly you notice this strange, sharp twinge in your lower abdomen.
Faint, but it's definitely there.
Yeah, and within maybe, I don't know, 3 seconds, your brain just skips right past the logical conclusion.
Like, I probably shouldn't have eaten that leftover takeout.
Right. You skip that entirely and land squarely on, well, my appendix is rupturing, I have a tumor, I am definitely going to die.
I mean, we all do it. The heart rate spikes.
The palms get sweaty, and the catastrophic spiral just begins.
It really does. But the thing is, the sources we're looking at for this deep dive today, they proved that this specific, totally relatable panicked thought is actually driving a global crisis.
A biological crisis,
Yeah.
right, which is wild to think about.
Absolutely wild. I mean, the connection between that private moment of panic on your couch and the collapse of the global healthcare infrastructure is incredibly direct.
So to get into this, we are looking at a pretty extensive stack of documents today.
We're starting with this incredibly stark UK policy brief. It's titled, Something Massive Just Happened Across the United Kingdom, and it's getting terrible.
Catchy title, and a bit terrifying.
Yeah, very. And we're pairing that brief with clinical neuroscience papers on a phenomenon called symptom amplification.
Those are by researchers like Dr. Arthur Barsky, right?
Exactly. And finally, we have these detailed business plans for a really revolutionary AI-powered healthcare model.
Right. Developed by Dr. Kadiali Srivatsa. So the mission for this deep dive is to trace that through line, from human psychology straight to systemic failure.
Because it's our desperate, anxiety-driven need for reassurance that is quite literally breaking centralized medical systems.
Specifically, we're looking at the UK's National Health Service, the NHS.
Yeah, and more importantly, we're going to explore this proposed solution, this decentralized artificial intelligence framework called the PRIMA kiosk.
PRIMA, which is designed to intercept that fear you mentioned, decompress the hospitals, and basically save us from what scientists call the post-antibiotic era.
Which is, I mean, the stakes here are totally existential.
They really are. You look at the World Health Organization projections, and antimicrobial resistance, or AMR, is on track to kill 10 million people annually by 2050.
10 million. That number actually eclipses the global death toll of cancer.
Wow. Wait, more than cancer?
More than cancer. And yet, the documents suggest we are fundamentally misunderstanding the whole crisis.
Because we treat it as just a biology problem.
Right, like it's just this war between brilliant scientists and mutating bacteria.
But the reality is that the root of the crisis is behavioral.
Exactly. We are creating this biological pressure cooker because of our own psychological inability to tolerate uncertainty.
So to understand that pressure cooker, we have to look at the numbers within the NHS, because they are just buckling under the weight of this human behavior.
Buckling is a good word for it. The system is facing a projected annual deficit exceeding £6.4 billion.
6.4 billion. With a B.
With a B. And across all the general practitioners, accident and emergency departments, specialists, they are processing an unfathomable 372 million appointments a year.
That is just a staggering volume of people. And the bottleneck there is brutal.
It's failing. The average wait time for a routine GP appointment in the UK right now has stretched to 14.5 days.
Which, if you think about it, when you are locked in that catastrophic mental spiral about a symptom.
Right, the tumor thought.
Yeah, telling someone to wait 2 weeks is functionally useless. Their anxiety just won't allow it.
No, of course not. So what do? They bypass the primary care system entirely and they just flood accident and emergency.
And that creates this massive financial hemorrhage. I mean, the sources note that every single unnecessary A&E attendance costs the NHS between £214 and £457.
Right.
When I first read that, I couldn't understand how a perfectly healthy, albeit anxious person walking through sliding doors could cost hundreds of pounds.
It seems high for someone who just needs to be told they're okay.
Exactly. But if we break down the operational mechanics, it makes total sense. It's not just a doctor looking at them and saying, you're fine.
Right. It's the triage nurse's time.
And the administrative logging.
The physical occupation of a waiting room chair or a bed.
A bed that then requires full sanitization. It is a massive misallocation of highly specialized, expensive overhead.
All being used to essentially dispense a pat on the back.
Right. But while the financial cost is staggering, the biological cost is actually catastrophic.
This is where we need to clearly define what antimicrobial resistance actually is, because that helps explain why this patient behavior is so incredibly dangerous.
Right, so AMR is basically Darwinian evolution, but happening at microscopic speed.
Yes. When a patient takes an antibiotic, it acts as a selective pressure.
It wipes out all the susceptible bacteria.
But it leaves behind this tiny fraction of bacteria that just happen to possess a genetic mutation.
A mutation that makes them immune to the drug.
Exactly. And those survivors then multiply. And the scary part is they can even pass those resistance genes horizontally.
Wait, horizontally?
Yeah.
Like to completely different species of bacteria?
Yes, exactly. To totally different species.
Oh, wow. So we are actively breeding superbugs by saturating the environment with the very poison meant to kill them.
That is exactly what's happening. And the sources point out this really terrifying spatial reality. Our centralized hospitals are functioning as the ultimate amplification zones for these pathogens.
Right, because think about the architecture and the airflow of a typical hospital waiting room.
It's basically a closed box.
A closed box gathering the most vulnerable, immunocompromised people in a community into one single space.
And then a patient arrives with a highly contagious mutating pathogen.
And because A&E wait times are feeling their 4-hour targets, I think they're hitting only about 73.9%.
Yeah, around there. So that infected patient sits in a poorly ventilated room for hours.
Just shedding pathogens everywhere. On the armrests, the door handles.
The magazines people read, and these pathogens form biofilms on surfaces that actually resist standard cleaning.
The documents cite colonization rates in these environments reaching up to 83%.
83%. It's mind-blowing.
So the visual I have in my head is someone walking into A&E with like a minor sprained ankle, completely healthy otherwise.
Right.
And they sit in that chair for 4 hours. By the time their name is called, they have inhaled or touched a multi-drug resistant organism.
They've essentially acquired a life-threatening superbug just by trying to get a bandage for their ankle.
The irony is so dark. I mean, a building designed for healing has become the primary vector for transmission.
The sheer concentration of sick individuals sharing space pretty much guarantees cross-infection before they ever even see a physician.
I was actually trying to think of an analogy for this. It feels like having a localized chemical spill in a neighborhood.
Okay, yeah.
But instead of quarantining the area and keeping people in their homes, the authorities mandate that anyone who even suspects they might have smelled the chemical must gather in a single crowded basement to fill out paperwork.
That captures the structural absurdity perfectly. You're just guaranteeing maximum exposure.
Right. And this brings us to the reality of what a post-antibiotic era actually looks like.
Which is grim. If these pathogens mutate beyond the reach of our pharmacological arsenal, we lose modern medicine as we know it.
Because we rely on the assumption that secondary infections can be controlled, right?
Yes, absolutely. Without that assumption, a routine cesarean section becomes a massive mortality risk.
Oh, wow, yeah. And joint replacements, organ transplants.
Chemotherapy, which literally wipes out your immune system, all of that becomes practically impossible.
Basic intensive care units would just turn into death traps.
The threshold for a fatal infection drops to, like, a scrape from a rose bush in your garden.
Which is terrifying. When you lay out the stakes like that, essentially a return to 19th century mortality rates, it forces a deeply uncomfortable question.
Why do we keep doing it?
Yeah. If hospitals are dangerous amplification zones, and most minor ailments are self-limiting viral issues that antibiotics can't even touch, why do rational people still run into the chemical spill?
Why do we demand to sit in that dangerous waiting room for every minor sniffle?
Right.
Well, to answer that, we have to pivot from epidemiology to clinical neuroscience, because the reality of human behavior is that we do not seek medical care simply because we are sick.
We seek care because we are terrified.
Exactly. The brain's processing of physical sensation isn't just a passive reception of data.
Right. When I was going through the neuroscience papers on viscerosomatic amplification, the concept of top-down processing completely shifted my perspective.
It's fascinating, isn't it?
It is, because my layperson understanding was always that the body is like a piece of hardware. A sensor in your stomach detects pain, sends a signal up the spinal cord, and a little alarm bell rings in the brain.
A bottom-up process.
Exactly, bottom up. But the research indicates the brain is more like a predictive text algorithm.
The predictive text analogy is neurologically spot on. The scientific term for this is interoception. It's the brain's perception of the body's internal state.
Right.
Areas of the brain, like the insula and the anterior cingulate cortex, they don't merely register a physical signal, they actively construct the conscious experience of the symptom.
By cross-referencing the incoming data with what? Your expectation.
Expectations, your emotional state, and your memories. They use all of that to build the sensation.
So the brain is essentially comparing what it feels with what it fears it might feel.
Yes, they converge. The cognitive and affective dimensions impart salience.
Which means they assign an emotional weight to a physical sensation.
Exactly. If you are already operating in a state of high anxiety, your brain literally turns up the volume on the neural pathways transmitting pain or discomfort. It creates this heightened state of monitoring.
And that heightened monitoring is what creates the phenomenon of viscerosomatic amplification. By focusing so intently on a completely benign sensation, we make it more noxious.
We literally make it hurt more.
The psychological analyses and the sources break this down into specific behavioral traps, and the most prominent one they talk about is the disaster movie mind.
Catastrophic thinking. It's really an evolutionary mismatch. Our brains evolved to be hypervigilant to physical threats.
Because missing a thread on the savannah meant death.
Right. But in the modern world, that hypervigilance is turned inward onto totally normal physiological fluctuations.
Like you stand up too fast, you experience a mild drop in blood pressure, which is just normal orthostatic dizziness.
A calm brain notes it and just moves on.
But the disaster movie mind immediately scripts a tragedy. It misattributes that benign dizziness to, say, a brain tumor.
And in a fraction of a second, you visualize collapsing, losing your job, your family suffering.
That scenario feels entirely real to the brain.
And the physiological consequence of that is profound. Because the brain believes the disaster is real, the amygdala triggers the autonomic nervous system.
You enter the fight-or-flight response.
Exactly. Your adrenal glands release cortisol and adrenaline. You experience tachycardia, racing heart. You start sweating.
Your breathing becomes shallow and rapid, which ironically provides the brain with a whole new set of physical symptoms to panic about.
Exactly. The brain says, look, my heart is hammering and I can't catch my breath. The tumor is progressing. I am actively dying.
It is a self-validating biochemical loop.
It really is. And that loop drives the second major psychological trap mentioned in the documents, the reassurance trap.
Right, because now the patient is thrust into this intolerable state of uncertainty regarding their own survival.
And the only way to lower that autonomic arousal to quiet the physical panic is to seek absolute certainty that they are not dying.
But the pursuit of certainty in biology is kind of a mirage, isn't it?
Completely. The reassurance trap is compulsive. It's identical to texting a friend, not getting an immediate reply, and spiraling into, are they angry with me?
Oh, I've been there. And then you finally ask them and they say, no, just busy.
And you get that massive dopamine hit of relief.
But that relief lasts maybe 10 minutes before the doubt creeps right back in.
Yeah.
Like, are they just saying that to be polite?
Exactly. The relief is temporary because the underlying intolerance of uncertainty hasn't been addressed at all.
This is exactly what happens with health anxiety. The patient isn't actually seeking medical information. They're seeking to eradicate an uncomfortable emotion.
So they turn to the internet, and what the documents call decision paralysis sets in.
The dreaded 3 a.m. Google search, we all know it.
Oh, yeah.
You start with a mild headache, and 45 minutes of algorithmic rabbit holes later, you are entirely frozen. You have mapped your mild headache to 10 different terminal diseases.
And your fear response is so flooded that trying to decide whether to take a paracetamol and go to sleep or call for an ambulance feels like trying to defuse a bomb.
We really have to emphasize how powerfully this top-down psychological processing alters actual physical reality. The clinical papers reference the nocebo effect to illustrate this, which is fascinating.
The nocebo effect is essentially the dark twin of the placebo effect.
Right.
In rigorously controlled clinical trials, 20 to 25% of patients who are given a completely inert sugar pill will report severe, debilitating side effects.
Like nausea, migraines, chronic fatigue.
Yes.
Just because the trial consent form warned them, they might experience those side effects.
Precisely. The expectation alone caused the brain to construct the physiological reality of the side effect.
That is wild.
We also see this mirrored in psychiatric conditions like anhedonia, which is often seen in major depressive disorder. Anhedonia is the total flatlining of the brain's dopamine-driven reward circuitry.
The sources describe anhedonia as making your favorite, most delicious meal taste like wet cardboard. Joy is physically absent from the sensory experience.
Exactly. So if the mind is powerful enough to strip the taste from food or manufacture a migraine from a sugar pill,
it is absolutely powerful enough to amplify a minor viral throat tickle into a sensation of life-threatening asphyxiation.
without a doubt. Which brings us to the operational collision. We have millions of people, the worried well, whose brains are trapped in these catastrophic loops.
amplifying benign symptoms and desperately seeking the narcotic of reassurance.
Right. So what happens when this massive wave of human panic crashes against a centralized healthcare system that is already fundamentally starved of time and resources?
It breaks the gatekeepers. I mean, in the UK, the theoretical first line of defense against hospital overcrowding is NHS 111, the National Telephony Triage Service.
Right. The idea is if you are panicked, you call 111 to get advice instead of rushing straight to A&E.
But the data shows this system is fundamentally failing to stem the tide.
Because the failure is structural. When an anxious, catastrophizing patient dials NHS 111, they enter this closed telephony loop.
First, they face an average wait time of 18 to 45 minutes simply for a callback.
And during that entire time, their autonomic arousal is just climbing and climbing.
Then when they finally connect, they are speaking with a call handler who is often non-clinical and who is rigidly operating an algorithmic decision tree.
It's basically a flowchart, a massive, inflexible software script. Does your head hurt? Yes. Is your vision blurry? Yes.
The critical limitation of a telephony algorithm is the total absence of visual and contextual data.
Exactly. The handler cannot see the patient's skin color, they cannot observe their breathing rate, or palpate their abdomen.
Because they're operating blind, and because both the software and the handler carry this immense burden of clinical and legal risk, the algorithm is intentionally biased toward extreme caution.
It's defensive medicine at an industrial scale.
Exactly.
When faced with a highly anxious patient who is describing amplified symptoms and possessing absolutely no visual data to refute the severity, the safest legal move for the algorithm is to default to the highest level of care.
Consequently, a massive volume of these calls conclude with the directive: go to A&E immediately.
Right. So a system explicitly designed to filter people out of the hospital is mathematically forced to funnel them right back into those dangerous amplification zones.
It's a complete paradox.
Yeah.
But what if the patient bypasses 111 and just waits the 14 days to see their primary care GP? The statistics here are arguably even more grim.
Very true. A GP in the UK currently averages roughly 6 minutes per patient consultation.
6 minutes. 6 minutes to welcome the patient, extract a medical history, conduct a physical examination, formulate a differential diagnosis, establish a treatment plan, and legally document the encounter.
It is an impossible temporal constraint.
And the patient walking into that 6-minute window has spent the last 2 weeks trapped in a disaster movie. They have amplified their symptoms, they are exhausted, and they are demanding an immediate, tangible resolution to their fear.
The patient is essentially using their panic as currency.
Which is a total inversion of historical medical sociology, right? The sources discuss this concept of the Machiavellian doctor.
Yes. Historically, the physician held absolute, unquestioned authority. They utilized a degree of paternalistic fear to ensure patient compliance, like, take this medicine or you will end up in the hospital.
But the modern paradigm has flipped. Now it is the patient leveraging the fear.
They weaponize the sheer intensity of their amplified symptoms. And that's often backed by the threat of filing a formal complaint or leaving a damaging review just to demand action from the doctor.
And in the context of primary care, that demand almost always takes the form of a request for antibiotics.
Let's trace the behavioral economics of the prescription pad in that little 6-minute window. Imagine a GP, deeply fatigued, maybe on hour 10 of a 12-hour shift.
Yeah.
Sitting across from them is a frantic parent with a crying child who has a mild viral fever. The parent is terrified. They're seeking the ultimate reassurance that they are a good parent doing everything possible to save their child.
But clinically, the doctor knows with absolute certainty that antibiotics are completely useless against the virus.
It's basic biological fact. Antibiotics destroy bacterial cell walls. Viruses don't even have that cellular structure.
But the doctor's looking at the clock. They have 4 minutes remaining.
And educating that highly anxious parent on the intricate differences between viral and bacterial pathology.
Explaining the global danger of antimicrobial resistance.
And coaching them through days of supportive self-care. That would take 20 minutes of intense, empathetic counseling.
And the parent is not in a receptive psychological state to just hear, go home and rest. They will feel dismissed.
They'll feel their fear was invalidated. They might become hostile, or they might simply take the child straight to A&E the moment they leave the clinic.
Costing the system another 400 pounds.
Exactly. Therefore, the path of least resistance for the exhausted GP is simply to print the prescription.
It requires 3 keystrokes.
It provides the parent with immediate, tangible, albeit entirely false reassurance. It diffuses the emotional confrontation.
And crucially, it clears the physical room so the doctor can move to the next patient in the queue.
The doctor is prescribing an antibiotic to treat the parent's anxiety, not the child's biology.
And that single, deeply human capitulation to fear, repeated millions of times across the globe every single day, is the engine driving us toward 10 million AMR deaths by 2050.
This system is perfectly trapped. We cannot surgically remove the capacity for anxiety from the human brain.
No. And we can't magically conjure 50,000 new, fully trained GPs to allow for 30-minute therapy sessions for every sniffle.
So if human doctors are being forced by exhaustion, time constraints, and legal fear into making dangerous prescribing decisions, the only logical intervention is to introduce a gatekeeper that is fundamentally immune to those pressures.
We need a triage system that cannot feel fatigue.
Yeah.
That cannot be emotionally bullied by an angry patient.
One that operates directly within the community and accurately separates the genuinely infected from the worried well.
Which perfectly leads us to the technological solution outlined in the business plans, the Prima kiosk.
Prima, personal, resourceful, empowering medical advice.
Developed by Dr. Kadiali Srivatsa. And it's important to note, this isn't just some tech bro from Silicon Valley pitching an app. Dr. Srivatsa is a former NHS consultant with 5 decades of clinical experience.
The physical manifestation of this concept is really fascinating. The documents describe a standalone, solar-powered, weatherproof terminal.
They call it a healthcare ATM, deployed as street furniture at village corners, local pharmacies, supermarkets, and petrol stations.
This physical deployment fundamentally decentralizes access. You don't need to navigate the friction of booking an appointment, securing transport to a clinic, or sitting in a contagious waiting room.
The triage capability is just embedded right in the routine geography of your daily life.
But the true innovation lies in the software driving it, Dr. Maya GPT.
Right, let's get into the architecture of this AI, because this is where I am inherently skeptical, and I think you, the listener, probably are too.
It's natural to be skeptical of medical AI.
We've all experienced the deep, soul-crushing frustration of interacting with an automated customer service menu that just doesn't understand your accent. Or a self-checkout machine loudly accusing you of placing an unexpected item in the bagging area.
Oh, the worst.
Right. And beyond that, we've seen modern generative AI models hallucinate completely fabricated facts with supreme confidence. So why on earth would we trust an AI kiosk standing outside a supermarket to manage human health and triage a sick child?
Who gets sued if it misses a subtle case of bacterial meningitis?
Exactly.
Well, those are the exact necessary criticisms. The liability and the accuracy are always the primary hurdles. But the documents clarify that Dr. Maya GPT is not just some open domain large language model scraping Reddit for medical advice.
Right. It's a highly constrained, specialized expert system.
It was trained explicitly on Dr. Srivatsa's 50 years of specialized clinical heuristics.
So the complex pattern recognition that a senior consultant uses to rapidly rule in or rule out dangerous pathologies.
Yes, it's essentially digitizing the intuition of a master diagnostician, rather than just cross-referencing Wikipedia.
Okay, that makes sense. But what about the liability and safety aspect?
The AI is designed with an asymmetric risk profile. It is not diagnosing, it is triaging.
So if there is any ambiguity, any conflicting data points, or any red flag indicators at all, the AI automatically defaults to a conservative escalation.
Exactly. It filters out the obvious benign cases with high confidence, which clears the noise, and then routes the complex or dangerous cases straight to human doctors.
The interface design also tackles a massive blind spot in modern health tech. The sources emphasize that globally, 760 million people do not own smartphones.
Which means entire demographics, the elderly, the economically disadvantaged, are just digitally excluded from app-based telehealth.
But Prima requires no app downloads, no monthly data plans, no complex login procedures.
It utilizes a voice-first interface capable of communicating in over 30 languages, paired with universally understood visual icons on a touchscreen.
So it achieves radical accessibility. You don't even need to be literate to receive high-level clinical triage.
And the documents also highlight a critical feature for public health, an anonymous, quick access mode.
I found this part brilliant. Think about the psychological barrier of stigma. If someone in a tight-knit, marginalized community suspects they have a sexually transmitted infection or tuberculosis, the sheer shame and fear of community judgment will prevent them from walking into the local clinic.
Because they might have to speak to a receptionist they know.
Exactly. Stigma drives disease underground, turning individual infections into silent community outbreaks.
But with Prima, An individual can approach the kiosk, select the anonymous mode, input their sensitive symptoms without providing identifying data, and receive immediate actionable advice on where to get confidential treatment.
The machine removes the human judgment that acts as a barrier to care.
Okay, so I see how it manages the patient's fear and bypasses the overloaded GP.
Mhm.
But how does this AI kiosk actually stop a superbug?
Right, the documents repeatedly refer to PRIMA as a biological firewall. How does a metal box outside a petrol station physically alter the epidemiology of antimicrobial resistance?
It alters epidemiology by fundamentally rerouting the movement of infected bodies through physical space. And the mechanism for that is the Dr. Maya color code triage system.
Ah, the color codes. Let's break down the logic of these.
The AI translates complex combinatorial symptom inputs into one of four incredibly clear color-coded directives. The first is the red code.
Which indicates the detection of life-threatening signs, right? Severe chest pain, stroke symptoms, major trauma.
Yes. The kiosk immediately advises the patient to call 999 or triggers an emergency response itself. It is a rapid escalation for genuine crises.
Standard emergency protocol. But what handles the worried well?
The yellow and green codes. A yellow code indicates mild discomfort suitable for self-care or maybe a consultation with a local pharmacist.
And a green code denotes a minor issue requiring simple monitoring at home.
Right. And these two codes are the primary weapon against the reassurance trap. The machine provides the anxious patient with an authoritative, medically sound evaluation that validates their symptoms but explicitly de-escalates their fear.
Empowering them with what the documents call body literacy.
Exactly. They get the reassurance they crave without demanding a GP's time or an unnecessary antibiotic prescription.
But the true engine of the biological firewall is the blue code. We really need to spend some time here because this is the paradigm shift for EMR.
It really is. The blue code signifies an infection risk. When the Dr. Maya AI detects a symptom cluster strongly suggesting a highly contagious or resistant bacterial or viral infection, it issues a blue code.
And the specific directive attached to that blue code is what matters. It explicitly commands the patient to isolate at home.
It provides a clear, authoritative instruction. Do not go to the hospital. Do not go to your GP's waiting room.
A return to your home, and the PRIMA system will immediately connect you via integrated telehealth to a remote doctor or direct a targeted prescription to your nearest pharmacy for pickup.
Let us analyze the epidemiological impact of this by contrasting two scenarios. We'll look at the R0, the basic reproduction number, indicating how many secondary infections one infected person will cause.
Okay. Scenario A, our current reality.
Right. In scenario A, a patient with a drug-resistant respiratory infection panics and goes to A&E. They sit in the waiting room for 4 hours.
Coughing, touching the water cooler, interacting with staff.
Yes. And they infect 3 vulnerable elderly patients who are in A&E for entirely unrelated issues like falls.
Those 3 elderly patients then develop severe secondary pneumonias, require massive courses of last resort antibiotics, and perhaps one of them dies.
The superbug has successfully amplified and spread deep into the community. The R0 in that hospital waiting room is effectively supercharged.
Now let's look at scenario B with the PRIMA network in place.
That same infected patient feels terrible, but instead of traveling to A&E, they walk 5 minutes to the PRIMA kiosk outside their local supermarket.
Within 2 minutes, the AI processes their symptoms and issues a blue code.
The patient turns around and goes home. They receive a prescription via a quick telehealth check-in. They recover in their own bed.
The R0 drops to 0.
Exactly. Those 3 elderly patients in A&E remain entirely safe because the biological fuel never entered the burning building.
That is incredible. And when we extrapolate this across thousands of kiosks deployed nationwide, we realize we have built a real-time, crowdsourced, epidemiological early warning system.
Because current public health infrastructure relies on lagging indicators.
By the time hospitals report a spike in admissions for a novel pathogen or a laboratory's culture and identify a resistant strain, the data is weeks old. The outbreak is already deeply entrenched in the population.
Well, because PRIMA is evaluating patients at day 1, right at the onset of their panic in the community, it captures the leading edge of the data.
The sources state that systems utilizing this framework have identified epidemic onsets up to 6 full days earlier than standard surveillance networks.
In the context of a highly virulent, rapidly mutating superbug, a 6-day head start is monumental.
It's the difference between deploying local, targeted containment resources to a single postcode and watching a pathogen spiral into an uncontainable national crisis.
The aggregation of anonymized blue code data gives public health officials a real-time heat map of biological threats.
The clinical logic is bulletproof, and the epidemiological benefits are massive. Which naturally brings us to the most cynical, pragmatic question. Who is paying for this?
The big question.
Right. We just established that the NHS is £6.4 billion in the red. The UK economy is under immense strain. Governments are not handing out billions of pounds for massive new infrastructure projects.
True.
How do thousands of advanced AI kiosks get funded without bankrupting the system or exploiting sick patients?
Well, this is perhaps Dr. Srivatsa's most revolutionary contribution. The Prima model is not begging for perpetual government subsidies or charitable handouts.
It's structured as a micro-franchise business model.
Exactly. It is designed to be a decentralized, self-financing network.
Walk me through the exact unit economics here. If I walk up to a kiosk, where is the money actually changing hands?
The system generates revenue through multiple streams, primarily small convenience fees for extended consultations or direct specialist connections.
Importantly, though, if a user registers as unemployed, elderly, or socioeconomically disadvantaged, the service is entirely free. It's subsidized by the broader network.
Yes. However, those who can afford a small micro fee for the convenience of instant triage pay it. Revenue also comes from document printing health reports or prescriptions printed directly at the kiosk.
And highly targeted localized health advertising displayed on the screens when the machine is idle.
Exactly. Eventually, hospital networks will pay subscription fees to access the anonymized epidemiological data and benefit from the referral routing that keeps their waiting rooms clear.
Okay, so money's coming in, but how is that revenue distributed? Because the instant you mention franchising in healthcare, listeners are going to assume this is a Trojan horse for corporate privatization.
Oh, for sure. People will picture a massive hedge fund extracting profits from sick people.
Right. But the business plan strictly guards against that through a transparent, triple-purpose revenue split.
Every pound generated by a kiosk is divided. 50% goes directly to the Dr. Maya Foundation. This is the humanitarian arm.
It funds ongoing global R&D, algorithm updates, and crucially, it cross-subsidizes the completely free deployment of Prima kiosks in low-income nations, refugee camps, and disaster zones.
So half the money immediately goes to global health equity.
That's huge.
Then 25% goes to the government or the NHS. This acts as a licensing fee and a direct contribution to the Treasury.
Meaning the kiosks actually generate income for the public health system rather than draining it.
Exactly. The final 25% goes to the local kiosk operator, the micro-franchisee.
The projections note that a single kiosk serving just 10 paying users a day generates significant annual revenue for the operator, all while saving the NHS hundreds of thousands of pounds in avoided A&E costs.
But the identity of these kiosk operators is what elevates this from a tech startup to a profound social intervention.
Right. Instead of funneling money into massive, faceless call centers for NHS 111, this model creates micro-businesses operated by kiosk guardians.
The demographic targeting for these guardians is brilliant. The UK has over 50,000 retired nurses and doctors.
These are individuals possessing vast reservoirs of clinical experience, deep empathy, and community trust.
Yet they are largely untethered from the medical system, often living on modest fixed pensions, their expertise completely unutilized.
So a retired nurse can acquire a micro-franchise and become the guardian of the kiosk in their neighborhood.
They oversee the physical machine, but more importantly, they provide the warm human reassurance that a metal box simply cannot generate.
If an elderly person is intimidated by the touchscreen, the guardian helps them navigate it. They contextualize the AI's output.
It creates a powerful synergy. The AI provides the flawless, emotionless, high-speed clinical logic, and the retired nurse provides the empathy and the human connection.
The guardian earns a dignified supplementary income. They remain socially active and respected within their community, and they serve as localized public health advocates.
The documents also discuss Maya advocates for marginalized or rural areas.
Right. Local women can be trained to operate these kiosks, becoming community health leaders and generating self-sustaining income in regions where employment opportunities are scarce.
The wealth generated by the community's healthcare needs stays within the community rather than being extracted by distant corporate entities.
It is basically turning healthcare into a grassroots economic movement.
We have a solution that addresses the psychological root of patient demand, functionally decompresses the centralized amplification zones, tracks outbreaks in real time, and creates thousands of local jobs for retired healthcare workers without requiring massive government debt.
The technology is proven, the economics are robust, so the inevitable final question is, why isn't there a Prima kiosk on every corner today?
What is the missing piece?
Yeah.
The final piece, as with all systemic transformation, is political will.
In Dr. Srivatsa's policy brief, he issues a direct, urgent call to action to the UK Secretary of State for Health and Social Care. And he is not asking for sweeping national mandates or billions in funding.
No, he's requesting a highly targeted pilot program. He wants the authorization to deploy 50 to 100 Prima kiosks across 3 diverse NHS regions.
One urban, one rural, and one socioeconomically deprived. The objective is to generate irrefutable, real-world validation data over a 6 to 12-month period,
proving the reduction in A&E admissions and antibiotic prescriptions.
The brief lays out the geopolitical stakes very clearly for the UK government, too. If they adopt and validate this system, the UK immediately positions itself as the global hub of AI-powered decentralized primary care.
It becomes a massive technological and humanitarian export.
Consider the global application. You can license this validated technology to Commonwealth nations, striving to build primary care infrastructure but lacking the capital to build physical clinics and train thousands of doctors.
The World Bank could deploy these kiosks across sub-Saharan Africa, where the doctor-to-patient ratio can be 1 to 50,000. It is a tool for global health equity.
But the brief also issues a stark warning about the cost of inaction. If Dr. Srivatsa does not receive the political and logistical support required to launch this pilot, the UK risks falling behind at a staggering pace.
The evolutionary trajectory of antimicrobial resistance is not pausing while bureaucrats engage in decision paralysis. The bacteria are mutating today.
Every single month of delay translates to hundreds of thousands of unnecessary antibiotic prescriptions.
Further entrenchment of superbugs in hospital amplification zones.
And a deeper financial deficit for the NHS. The march toward 10 million deaths by 2050 is active.
There is a quote in the source documents from Dr. Srivatsa that I really want to highlight because I think it encapsulates the entire philosophy of this movement.
What does he say?
He wrote, "The greatest mistake in healthcare is treating the sick, and the greatest achievement is keeping people well."
That is a profound reorientation of medical ethics.
It is. He observes that medicine was originally conceived as a moral profession dedicated to holistic community wellness, long before it devolved into a commercialized activity optimized for processing sick bodies and maximizing quarterly earnings.
The Prima system is fundamentally an attempt to reset that moral compass through technology.
By prioritizing early community intervention, systemic defense, and human empowerment over reactive, expensive, centralized treatment.
We have covered an immense amount of complex territory today. Let's synthesize the journey of this deep dive.
Let's do it.
We started by examining how the deeply human evolutionary mismatch of our anxiety, that disaster movie mind and viscerosomatic amplification, drives us to flood centralized medical systems.
And we analyzed how that overwhelming wave of terrified patients collides with exhausted doctors and flawed algorithms,
forcing the overprescription of antibiotics and turning hospitals into amplification zones for deadly superbugs.
We then unpacked Dr. Srivatsa's solution, the Prima kiosk and Dr. Maya GPT, a decentralized, AI-powered biological firewall that intercepts human fear directly in the community.
It uses rigorous, color-coded triage to isolate infections at home, breaking the chain of transmission,
while simultaneously creating thousands of dignified micro-business opportunities for retired nurses through a self-sustaining franchise model.
It really demonstrates that artificial intelligence doesn't have to replace the human element of medicine. It can be deployed to protect the human systems from our own behavioral flaws,
allowing humans to focus on empathy rather than just processing data.
So to you, the listener, the next time you're sitting on the couch and your brain hits the panic button over a strange rash or a persistent cough, realize that your anxiety is a completely normal evolutionary response.
But recognize that blindly following that panic into a crowded waiting room has massive macro-level consequences for global biology.
Imagine the peace of mind of walking down to your local corner shop, consulting with a friendly retired nurse, and getting a flawless, color-coded clinical answer from an AI in 2 minutes.
Rather than waiting weeks in fear or risking exposure to a superbug.
That decentralized, empowered reality is the future the Prima model is offering, if the political will exists to embrace it.
It's all about making that shift.
Which leaves us with a lingering, provocative question to ponder on your own. As artificial intelligence becomes increasingly sophisticated at diagnosing the physical mechanics of our bodies with cold, hard, objective logic, will the future role of human doctors shift entirely?
It's a huge question.
Perhaps the medicine of tomorrow won't be about humans solving the biological puzzle at all. Perhaps the machines will be tasked with curing our bodies, while the human guardians are left simply and beautifully to cure our fear.